and welcome to Guest Room. This is me, Anjali, here with you. Today we have a special guest, a well-known interventional cardiologist who has come all the way from Canada. Let's welcome Dr. Dzavik to the show. Hello, Doctor.
Thank you very much.
You're welcome. First of all, we would like to know more about you.
So I'm an interventional cardiologist, which means that I am a cardiologist, a heart specialist, but I also specialize further in opening blood vessels of patients who have blocked blood vessels in the heart by means of balloons and stents, which are wire meshes to keep the blood vessels open. I also head up the cardiology program at our hospital, the Toronto General Hospital University Health Network in Mount Sinai in Toronto, Canada.
How does this blockage happen?
The plaque starts occurring very early in our life, when we're children even. So the plaques begin to occur through buildup of cholesterol, through inflammation, and these plaques grow over time and can cause a very severe blockage, which then causes chest pain called angina, which occurs when a person is exerting, when they're walking up the stairs or walking up a hill or along the street, along a road. And that's when angina usually starts to occur, when the narrowing becomes severe. Now, the other thing that can happen then, even when the narrowing is not so severe, which is why people will often have heart attacks without having had any chest pain with exertion previously, is that the plaque is unstable. It's called an unstable plaque, and that plaque can rupture. Unstable means that the tissue there is all inflamed and all full of cholesterol, and at some point, if you wish to put it simply, it kind of bursts. When it bursts, a blood clot forms inside the blood vessel, and that's what causes the ST elevation heart attack. The blood vessel is closed by this clot, which results from the ruptured plaque. And the blood vessel blood wants to heal itself, so it causes this blood clot to form. And that's the problem.
And when can this plaque buildup be identified?
Well, oftentimes it can be identified if a person is having this chest pain that I discussed called angina, which occurs with exertion. Sometimes it can't. Sometimes it occurs out of nowhere. As I mentioned, when the plaque isn't so severe, but suddenly it ruptures and now becomes completely blocks the blood vessels suddenly. But we know that lots of people are at high risk for such plaque buildup, and we recommend good lifestyle measures to prevent this from happening. So you cannot always predict it, but you know when somebody's at higher risk that they should be taking precautions to reduce their risk of such an event occurring.
Other than ST-EMI, is there a non-ST-EMI?
I had already mentioned that there is a non-ST-EMI where the blood vessel isn't completely occluded, completely blocked. And so we have to deal with that usually with intervention, with mechanical opening of the blood vessels, but usually not as rapidly as with the ST elevation MI, which needs to be dealt with as soon as we identify the problem. Because the muscle at that point with the ST elevation MI is dying. It's lacking oxygen, it's lacking blood, so it's lacking sustenance, and it's dying as we speak. The quicker we can open that blood vessel, the greater the likelihood that we will salvage or save some of that heart muscle, and that the patient will have a smaller heart attack and less of a risk of dying.
So you say ST-EMI is much more dangerous than non-ST-EMI?
It's much more dangerous early. So early, we need to deal with it very quickly. The non-ST elevation MI, we can usually treat a patient with that kind of a myocardial infarction not quite as rapidly. We can institute medical therapy, medicines, that will stabilize the situation, but we still have to take the patient to a catheterization laboratory, which is an X-ray suite where we can do an angiogram, a dye test, by putting a tube, a catheter, either in the wrist or in the groin, and through that inject dye, which we see with the X-ray camera. That allows us to see where the blockages are and whether we can open them with angioplasty and stents, or on occasion, it may be so severe that a patient may need bypass surgery, open heart bypass surgery.
It is usually heard that heart attacks is caused due to high cholesterol. Is there any other factors which affect the same?
There's no question that high cholesterol is a major risk factor, but there are, of course, others. Cholesterol itself is a genetic factor, so your family history determines how high your cholesterol is going to be, and there's some modification of that through the diet that we eat. So the more fatty foods, the more sugars, sweet foods we eat, the higher the cholesterol, and the triglycerides, which are also a determinant of risk, which are part of the whole cholesterol molecule picture, will be. We strongly recommend smoking cessation, control of high blood pressure. Diabetes is another major risk factor, and here in India, I think that's an epidemic, and it is where I am in Canada as well. So diabetes is a major risk factor. There are many other more rare conditions, but these are the major factors that we talk about. Sedentary lifestyle.
Is blockage of artery the only reason for heart attacks, or does cardiac infections and birth defect play a role in it?
In rare cases, birth defects can, by virtue of the fact that sometimes the blood vessels can run a course that can occasionally block it by other larger blood vessels. You also mentioned infection, and that is actually probably not an uncommon cause of blockage of the blood vessels. So an infection per se won't cause a heart attack. An infection for a viral infection can cause weakening of the heart muscle. This we call inflammation of the heart muscle, a myocarditis, and that can become quite severe to the point where a patient may need a heart transplant or have severe heart failure. That's not really called a heart attack or myocardial infarction, but that's a different process where the heart muscle gets weak. But infection, in particular oral infection, so people who have poor hygiene, we know are at higher risk to develop blockages in their blood vessels. And these blockages may be because of the increased inflammation that's in their entire body that affects also the blood vessels in the heart.
The blockage of arteries leads to heart attack.
Blockage of arteries in the heart leads to heart attack. Coronary arteries leads to heart attack, yes.
Okay, then what do you mean by coronary intervention?
So coronary intervention is where we try to unblock these arteries with, through, as I mentioned before, where we put catheters, tubes either through the wrist artery or through a groin artery, and then we put a little wire into the blood vessel, over that wire a balloon which we can inflate, and that unblocks the artery. Now, just using the balloon, that artery, all that plaque that we just pushed aside can collapse and close the blood vessel again. So what we've been using really since I would say for close to 20 years now, are devices called stents. Stents are little wire meshes that are crimped on the balloon, and when you inflate the balloon, the stent is expanded. You then deflate the balloon, the stent stays in the blood vessel, scaffolding the blood vessel so that the material doesn't collapse back onto and block the blood vessel again. So that's what we mean by angioplasty, stenting, coronary intervention.
What are the latest advancements in the area of stent?
So the latest advancements are drugs. Stent is a metal device in general, although there's some new ones that are actually made of plastic that, believe it or not, will dissolve over a year and a half to 2, which is thought to be an advance. It's still early in development. There are some promising results, but we still need more research to understand whether this is going to be better than metal stents. But a less recent advance, but one that keeps moving along, is the application of drug onto the metal. Now, a metal stent, the metal inside the blood vessel, your body sees that as something foreign, something that it wants to get rid of. So there will be a collection of inflammatory cells, cells that try to fight a foreign body, basically. So they cause inflammation, and this inflammation will cause blockage inside this stented segment by building up new tissue, which is abnormal. The drugs that are coated onto these stents prevent this inflammation reaction from occurring and reduce markedly the risk of re-narrowing within these stented segments in the blood vessels. So these are, I would say, some newer advances, and the drugs are getting better, the materials of the stents are getting better, and as I said, the most recent one is the introduction of these plastic stents. The plastic material actually is a polymer that's of a material that's in our bodies. It's made of lactic acid, actually. So it's called polylactic acid, and so when it resorbs, it's actually a molecule that's in us already, so it doesn't really affect us negatively. And there are promising results, as I said, though more research needs to be done.
What do you mean by PCI?
PCI is percutaneous coronary intervention, or angioplasty, to open these blockages in the blood vessels in the heart.
Why are some heart attacks silent and some painful?
It's a very good question. So people who are diabetic, for example, for some reason, because of perhaps damaged nerve endings, whatever, are less likely to feel pain when there is decreased blood flow to their heart. So they will have what we call silent ischemia. Ischemia means lack of appropriate blood flow to the heart muscle. Similarly, they can have silent heart attacks. So we not uncommonly see people who we do dye tests or angiograms on who it's quite clear have pre-existing blockages that they never felt. And then why some people will have a silent heart attack that may actually kill them, unfortunately, at first, is because they had no severe blockage previously, and suddenly they have this plaque rupture, and suddenly a big blood vessel, important blood vessel, blocks, and the heart just isn't able to deal with it. The heart may actually go into what we call ventricular fibrillation, which is a severe rhythm disturbance where the heart is ticking along at 400, 500 beats per second. At that rate, it can't really keep up, and it does nothing. It's disorganized kind of terminal activity. It can be stopped with defibrillation, but often needs the opening of the blood vessel to completely treat.
As you have already told, heart attacks or the blockage, the plaque formation is a chronic process.
Yes.
But especially in India,
yes,
we find people at the age of 30, they get more concerned about their high cholesterol.
Well, this is good. This is good that they're concerned, and they should be, because whereas the plaques begin to form in childhood, it's in the 20s and 30s and 40s that the plaques actually then begin to encroach on the lumen or on the inside of the blood vessel, restricting blood flow. But this is also the time when they build up to such an extent, even if they don't block the blood vessels, that they are prone to this plaque rupture and this sudden heart attack.
What do you mean by CPR, doctor?
CPR, or cardiopulmonary resuscitation, so that person who dropped dead from their heart attack, and CPR means, and everybody should know how to do CPR. They should take a CPR course, and CPR is where you're compressing the heart, which allows some blood flow, usually enough blood flow, to the tissues, to the vital organs, to sustain life for a short period of time. And that short period of time, you know, we've seen people saved even maybe as long as 20, 25 minutes of CPR, if the CPR is begun immediately after the person drops dead. Beyond that, really you need more advanced support and more advanced intervention, but CPR itself can keep a person alive for 20, 25 minutes if it's begun immediately and if it's done adequately. meaning adequate force. That's why everybody should really take a course in this, so that they can help their loved ones if this happens to somebody.
Can you give us a brief explanation about the ECG?
So ECG, or the electrocardiogram, is the heart has electrical activity, okay, which we can measure by putting wires on the chest. And this electrical activity is documented as a tracing, on which I'm sure most people have seen or are familiar, though they couldn't interpret it, but I'm sure they can recognize what an ECG is. So it's basically a recording of the electrical activity of the heart. This electrical activity then causes the heart muscle to contract on a regular basis. So the ECG represents that electrical activity, and there are many abnormalities that we can diagnose from different waveforms, from different tracings of the ECG.
Is there any relevance of keeping the leads of an ECG at particular positions?
Yes, there are. So the standard ECG or electrocardiogram has 12 leads. And these are placed in very standard positions on the arms, the body, and across the chest. These are standard so that we compare every time an ECG is done. We see the heart from exactly the same locations every time. Okay? And these locations represent different parts of the heart muscle, the different chambers and the different parts. So for example, the front, the back, the right side, what we call the lateral or off to the side. And we know that if we did an ECG on a person a year ago, and we do an ECG on a person today, and the tracings look different, it's because we know they look different because the leads were placed in essentially the same location or very, very similar location. And each of the leads tells us something about a different part of the heart muscle. So it tells us, it identifies for us which blood vessel may be blocked. There are two major blood vessels, and the left one has two major branches, a front one and a back one. And the right one has is one major vessel with some smaller branches at the very bottom. These leads tell us, for example, if an ST elevation or this deflection, this upward deflection occurs in certain leads, we know that it's in that location, that part of the heart muscle, where the blockage or the ST elevation infarct, for example, is. So yeah, it's very relevant.
What do you mean by the term cardiac arrhythmia?
So a cardiac arrhythmia is an abnormal rhythm of the heart. The heart has its own internal pacemaker, which keeps ticking all our lives, and sometimes this pacemaker becomes abnormal, so that it either other pacemaker takes over, which makes the heart go very quickly, and to the point sometimes where it doesn't sustain life. Or, on the other hand, and more commonly in older people, the natural pacemaker of the heart actually deteriorates and starts pacing more slowly to the point where a person may collapse. And this is the kind of person who then needs a pacemaker inserted if their heart starts going too slow. So that's what we mean by that.
What are your present researches?
So my present research involves improving, I have several lines of research. I work with the patients with heart attacks, with severe heart attacks and cardiogenic shock. I'm just starting a study, a multi-center study, looking to see whether a new medication will reduce the size of the heart attack in patients who are having stent procedures in the setting of a heart attack. Also looking at doing research with complex disease in the coronaries and looking at new techniques and new materials to improve outcome in patients who are undergoing angioplasty for those settings. And basically that's what I'm doing, to put it simply. Yeah.
Thank you for spending your valuable time with us. It was
pleasure.
A great time with you.
My pleasure. Yeah.
So that was Dr. Dzavik with us. Until next time, this is me, Anjali, signing off. Take care.
Oh,